Welcome back to part 6 of our 100-part CPC exam series. Now, if you are prepping for that CPC exam and you find yourself constantly second-guessing your skin and wound codes, well, you are in the exact right place. Today, we're decoding the integumentary system. It's an incredibly fascinating area, but, it's also one where medical coders get tripped up by the tiny details all the time. But we're going to make sure that absolutely doesn't happen to you in this explainer. So before we even start looking at the codes themselves, we have to ask a massive question. Why does depth actually matter so much? Well, in the integumentary system, which, by the way, covers your skin, hair, and nails, the physical location, the depth of penetration, the size, the number of lesions, and the specific tissue involvement are literally the ultimate drivers of your code selection. If you don't know exactly how deep a wound goes, you simply cannot code it correctly. Now, before we peel back the layers of today's lesson, make sure to like, share, and subscribe to Decode Healthcare with Herschel. Doing that really helps us keep creating this structured, high-yield content to get you fully exam ready. Okay, here is our roadmap for this explainer. Number 1, a coding overview. Number 2, skin layers and accessory structures. Number 3, common pathologies and documentation. Number 4, key procedural terminology. And finally, number 5, a summary cheat sheet and teaser to lock it all in. Let's dive right in. Section 1, Coding Overview, Integumentary System. These 5 bullet points right here, they are your holy grail. When you are reading a patient chart or tackling a tough exam scenario, you must actively hunt for the anatomical location, the depth, the size, the number of wounds, and whether there's specific tissue involvement like infection or necrosis. These are the core drivers that dictate your accurate CPT and ICD-10 CM code selection. Seriously, if you're ever staring at a tricky multiple-choice question, these 5 elements are exactly how you eliminate the wrong answers.
Moving right along. Section 2, Layers and Structures, Skin Anatomy.
It is amazing how perfectly our anatomy maps directly to coding terminology. Just look at the epidermis. It's that superficial barrier right on top with 0 blood vessels. So when the clinical documentation says superficial, boom, you are in the epidermis. Next down is the dermis, which is the functional layer packed with vessels and nerves. This is your partial thickness keyword. And finally, the deepest layer is the subcu or subcutaneous layer, which is made up of adipose or fat tissue. If a note says full thickness, it almost always implies the wound has punched right through the dermis and deep into the subcu layer. And embedded right within those layers are our accessory structures. We've got hair follicles rooted in the dermis, keratin-based nails, sebaceous or oil glands, and sudoriferous sweat glands. Why does this actually matter for you? Well, because if a patient comes in with an inflamed sebaceous gland, like a cyst, right, knowing that it originates down in the dermis directly impacts the clinical description and ultimately the pathology code you're about to choose. All right, Section 3, Common Pathologies Documentation Prompts. When you are reading a chart, these are your exact look-for prompts. For dermatitis, you've got to look for the trigger and chronicity. For cellulitis, hunt down the site and any systemic signs, like a fever. For pressure ulcers, you absolutely need the exact stage, from I to IV, and the precise anatomical location. For burns, the depth and the total body surface area, also known as percent BSA, are totally non-negotiable. Missing just one tiny detail, like the stage of an ulcer or the BSA of a burn, will completely derail your claim. Almost there. Section 4, Procedural Terms, Key Terminology. First up, biopsy versus excision. We have to draw a hard line here, guys. A biopsy is just removing a tiny sample of tissue to figure out a diagnosis. And excision, that is the surgical removal of the entire tissue or lesion. So, rule of thumb, if the doctor just takes a little piece to test it, it's a biopsy. If they got the whole shebang out, it's an excision. Next, let's look at debridement versus skin grafting. Debridement is basically wound site cleanup. You're just removing dead or infected tissue to help a wound heal. A graft, however, is a much bigger deal. It's the physical transfer of skin from one place to another. For a graft, your documentation must explicitly state the donor site, the recipient site, and the exact size. Without all 3 of those, your claim is definitely going to bounce right back. And finally, Section 5, Summary Cheat Sheet, Integumentary Review. You made it. Go ahead and take a quick screenshot of this one-page visual summary. Remember your main drivers: location, depth, size, and number. Memorize those skin layers. Epidermis is superficial, dermis is partial thickness, subcu is full thickness. Always, always hunt for stages in ulcers and BSA in burns.
And whatever you do, never mix up a simple biopsy sample with a full excision.
Fantastic work today, but we are just getting started. Next up is part 7, where we tackle the musculoskeletal system. We're going to be diving deep into bone structures and joint movements, and I'll leave you with this. Do you know the exact rule for coding a strain versus a strain? There is a very specific trick to it, and we are going to cover it next time. Until then, keep studying, and I'll see you in part 7.